Hello, my name is Laura Moss and I'm a student at St. Joseph University's course, Healthcare Informatics at the graduate level. I am recording an assignment about transforming healthcare through secondary use of health data. First of all, we'll discuss what is secondary data. Secondary data, if you think about the continuum between data, which then can be used to achieve information, and then knowledge and wisdom. Data in the information form through analytics is used to identify and evaluate trends that impact several areas in healthcare, including cost savings. If we are able to analyze where we're spending money, then we can decide how we can save money. Also, revenue enhancements. If we're able to use data to identify a need, that can enhance our revenue because we can provide that service. And also consumer satisfaction based on outcomes. Discuss for the remainder of this video all of the aspects of use of secondary data from the skilled nursing facility industry. Long-term care is where I work, and so I will use that as a reference point for all of my discussion. Data in all areas of healthcare, and particularly in long-term care, is used for the internal use for quality improvement. We use that secondary data to look at issues of concern that are measured, such as the use of side rails, which are a restraint in our world, weight loss, which is an issue, skin failure, breakdown, psychotropic medication use, pain management and control, and across the healthcare spectrum, we're all looking at rehospitalizations. So internally, we're looking at all of those things. And then when you look at how we use secondary data externally, that is a growing area for us. We have actually been participating in linking up and collaborating with other healthcare entities in our area to form a regional health information exchange. And it's in the early stages, and we plan to start with the sharing of ADT data, admission, discharge, and transfer data, that will help us just get into the practice of sharing data so that we can expand that practice later. One thing that we've used secondary data for, or I see a place for secondary data, is I was assigned as a quality analyst to make 30-day post-discharge calls to our nursing home residents if they went home. And what I found making these 30-day calls was actually an unexpected thing. And that was that the Certified Home Health Agency that was covered for skilled services for Medicare A after discharge from the nursing home is just about pulling out of the home at the 30-day mark. They've had roughly 4 weeks. They've had physical therapy or occupational therapy or nursing or wound care, and at that 30-day point, those entities are leaving the home, but these individuals still have needs. They're actually nursing home appropriate people, but they prefer to be in their homes. So they still have care needs that are not covered by Medicare, and they can fall through the cracks. How can we solve problems and meet needs? That's what we need to look at doing. So we're in the infancy of that idea. How do we use this for referral streams, both that we can refer to others when we see these needs? Could I make a referral once I've made this call to the County Office for the Aging, or could the Office for the Aging contact me? Some other barriers to technology are that hardware, software, and server space are expensive. And long-term care facilities are not incentivized in the same way that hospitals and physicians are for the achievement of an electronic medical record. So we have the same expectation. We still have to achieve meaningful use, but we are not incentivized in any way, and that has been an issue. And once we try to build that infrastructure, which is costly, there's almost continuous updating and upgrades that have to be done. And then when we look at the health information exchange and interoperability, there's costs associated with linking up with that, with the security and privacy issues, having an HL7 interface, all of those different things. So that's been a barrier and a concern for us. In the article, I thought it was interesting, in the Price Waterhouse Cooper article, there was a quote that said, you need to hire the best and brightest data experts if you want to achieve this meaningful use of secondary health data. And what I see with that is there have got to be clinicians involved in developing software. It's very clear when you look at healthcare software that so much of it is developed and not designed by clinicians and not with their input, because a clinician would not be developing this software in the way that it's developed, that's not efficient, that's not able to be used. For example, when I was a quality analyst and I was trying to take a look at side rail use, I was not able in our electronic health record software to come up with a side rail use report. Even though it's part of the care plan, there should be a way that you enter side rails so that you can extract a report. Without that, it's necessary to go and count side rails, the old school. Also, one way that I see that our software program is not meeting our needs is the fact that almost every person in a management position has an Excel spreadsheet that they use to record something that they're responsible for. And that, in our reading, was called the normalization of deviance. And when I saw that, it really rung a bell for me. It was an aha moment, because we do a lot of normalizing deviance because we do things that work around our system, these end runs, because we can't satisfy the need we have with our system. And coming to a point where you can achieve reliable collection of data and data mining so that you can use it as information and use it as secondary data will not be achievable until you have systems that make it efficient for you to do that. I hope this provides a good overview of what secondary health data is, how it can benefit those of us in healthcare, and what some of the barriers are. Thank you.